All right, folks, we'll get started. Thank you, everyone, for coming to our very last PNB Colloquium talk for the 2023-2024 series. It's fantastic to be able to finish the series with a speaker in our very own department, Dr. Paul Andrews. I will keep my introduction short because I'm sure we all want to listen to him, not to me. So Paul got his Bachelor of Science in Aerospace Engineering in University of Arizona, 1990. Very different background than most other psychology faculty. He then deviated further away from psychology and got his JD, became a lawyer in 1995 from University of Illinois. And then a little bit after that, he got his PhD. Graduated with distinction in biology from the University of New Mexico in 2002. And then, I don't know how long you've been here, 10, 15 years now? About?
Since, 2011?
2011. So 12 years ago, he joined McMaster as a professor to lead the Evo Health and Physiology lab here in our department. He studies and is interested in fascinating topics of depression, which we're going to hear a lot about rumination today. I have the unique perspective in teaching several undergraduate courses, and I get to sort of get the lay of the land, how the students sort of take in Paul's approaches to ideas such as depression. And I will say, as a student, when he joined the department, there was a lot of resistance. And I can comfortably say that there's a lot of acceptance in a lot of Paul's ideas amongst the student population. So I think that's really exciting to have seen that change. So and if ever you need someone to sing at a karaoke, apparently Paul is fantastic at that. So without further ado, please welcome Paul.
Thank you very much. It's actually, I've been looking forward to giving this talk because so much of my work deals with other university things nowadays that it's so nice to be able to come and talk about research. So can everybody hear me okay? Okay, great. And just want to say, I guess you probably all know it's a talk on depression. Obviously, there's some sensitive topics here. I assume you're all aware and comfortable with that, or if you're not comfortable, you're at least willing to have the uncomfortable feelings that come with a talk about this topic. We've all have some sort of experience with depression. Many of you, we all kind of know what it is. Either we've had the experience ourselves, we have friends or loved ones who have it, and as educators, we're facing it quite a bit in the context of students who need accommodations for depression or anxiety. So we think we know a lot about depression, but over the course of my lifetime, I have seen the cultural narrative about depression change quite dramatically. Back when I was growing up, the 70s, the depression was considered, and there's a variation in how people think about depression then as well as now, but I'm giving you sort of stereotypical kind of perspectives. They're obviously not uniformly held. But back in the 70s, depression was basically considered a normal emotional response, yes, painful, but a normal one to many serious problems in life. Things like for young people going through puberty, having issues with sexual identity, for older people, divorce, financial problems, etc. And in that context of it being a normal emotional response, it was also generally considered an important learning experience. People, as they were growing up, had to learn how to manage their feelings of depression and anxiety. And so in that sense, it was considered a normal part of development, and even promoting resilience to handling other stressors as you grew up. Yes, it is true that there was some stigma associated with depression. Not so much in the having the experience, but in the seeking out help for it. And I have to say, everything that I remember about that was particularly stigmatizing to seek out psychiatric help, right? Not so much a clinical psychologist or a social worker, but a psychiatrist. Maybe for a lot of these reasons, depression was usually untreated. That doesn't mean that people didn't seek out help informally with their friends and their families. And how their friends and families responded to you might differ. And if, in general, if it was treated formally, it was usually with some form of psychotherapy. It's only in the late 80s that antidepressants really started becoming more prominent. And of course, now the story, the cultural narrative is very different. It's considered a recurrent mental disorder. And what I mean by mental disorder is that something in the brain is not working properly. Again, that's not something that every person views nowadays, but that is the predominant view. Depression is something where the brain is not working properly, particularly if it causes persistent distress. Persistent could be on the order of weeks or months. The leading hypothesis for the cause of depression is stressors interact with the brain. People differ, however, in how vulnerable their brains are to producing a depressive response. We call that a diathesis. So it's that interaction between a vulnerability, diathesis, and the exposure to stressors that produces a depressive response. Depression is not considered useful at all. In particular, depressive thinking is not considered useful at all. It's a leading cause of disability and economic costs, so it should be cured or at least suppressed. And of course, by now it's completely reversed. Whereas medications were very infrequently prescribed back in the 70s and 80s, now it's the reverse. Nearly 80% of people who are treated for depression will receive an antidepressant medication. And by the way, that's not something that most people want. That predominance of antidepressant medication as a treatment for depression exists despite people's preferences. Most people want to have a psychotherapist or somebody they can talk to. Okay. Now, there have been a number of criticisms of this current narrative produced by many, many prominent people who are psychiatrists and psychologists, people who actually wrote previous editions of the Diagnostic and Statistical Manual, the DSM, that is used for diagnosing mental disorders, former heads of the National Institute for Mental Health, which in the United States it's actually one of the world's leading institutes for setting research funding for mental disorders. All of these prominent people have raised serious concerns about the current narrative. One, the diagnostic criteria for depression lack validity and pathologize normal emotional responses. Two, there's no evidence that depression is actually caused by any dysfunction in the brain. And where people like me come into this narrative is we take these two pieces of evidence, and with our evolutionary background, we propose that actually it's a normal emotional response. It evolved, and it produces useful effects. But, we're still a minority, but that's where we'd fit into this picture. And then the other major critique is that antidepressant medications are neither safe nor effective. Okay, with really prominent people making these criticisms, it's kind of surprising that they have not had more impact on how we think about and treat depression in our culture. And there are probably several reasons for this, one of which might be it's hard to replace a flawed paradigm without having a better one to put up in its place. But why is it we don't have good alternative paradigms? Well, one, I think, is the fact that we actually, as you might easily imagine, lack any experimental control over the psychological phenomena of depression. And so we've had to result in mood inductions like sadness, but don't produce the whole syndrome of symptoms that occur with depression. Or we use people with pre-existing depression and use case control studies, or we take do correlational studies where we look at the degree of depression and associate it with many other things. So it would be really helpful if we had an experimental paradigm that we could use to trigger and study depression, the syndrome, in the laboratory. Another thing that I think is crucial to changing the narrative is to actually be able to identify what the function of depression is. If it's a normal emotional response, like anger or love, infatuation, jealousy, guilt, those kinds of emotional feelings. We have already an intuitive understanding of what those emotions do, but we've had some difficulty isolating what it is that depression does. So I situate depression in a larger context of aversive feelings because we've learned a lot about aversive feelings generally. In general, they do promote what I would just call escape behavior and avoidance learning. So I've got this picture of a fish. I don't know if, is my thing actually working here? Okay, I know it's here, so I have to be, it's probably not worth doing. Okay, picture of a fish who's been caught by a hook, and it's struggling, and it's trying to escape, and presumably it's feeling some pain that is motivating it to try and escape from being the hook, which is causing tissue injury and probably is going to lead to death on somebody's dinner table. So physical pain promotes escape behavior, but also avoidance learning. And I've got this other picture here about operant conditioning, just to highlight, because it's a phenomena that we're all familiar with from our studies in psychology, right? And operant conditioning essentially involves the use of punishment and reward to shape behavior. But the punishment part inherently relies on producing aversive feelings, painful states, like shocking a rat or something like that. Okay, so we've got a whole slew of different kinds of aversive feelings up here. Hunger, jealousy, shame, fear, anxiety, disgust, anger. And I've got a whole slew of proposed threats to which they are responses to. And that the aversive feelings produced by each of these states help promote either escape behavior and or avoidance learning of those things. And again, operant conditioning is you train the animal through a schedule of punishment to shape its behavior in ways that it's trying to avoid being exposed by the shock, etc. And it learns how to do that. Okay, is everybody comfortable with the idea of avoidance learning and aversive feelings and their role in that? Okay, great. Now, I study a particular type of depression, which I'm going to call melancholic depression, but I might call it ruminative depression too. There are different types of depression, and it's important to be particular about which one we're talking about. But this is the one that you would probably be most likely to think of as depression too. It's characterized by a number of symptoms here. One is rumination, intense, persistent, distraction-resistant thoughts. Ruminative thoughts in the context of depression often have themes of guilt or self-blame or worthlessness or low self-esteem. The symptom of sadness. We know from a lot of research in social psychology and cognitive psychology that sadness promotes a type 2 or system 2 type of processing style, which if you've had a course in cognitive psychology, you'd recognize as slow, methodical, careful. It's attentionally demanding, time-consuming, and energetically expensive. And that's because it involves the use of working memory, which has all of those qualities. Type 2 thinking is often analytical in nature. What I mean by analytical? It means it's a divide and conquer processing strategy. You've got a complex problem, and it's too difficult to figure out on its own, so you chunk it into smaller, more manageable pieces and study the pieces sequentially. So divide and conquer. And because you have all of these pieces that you have to keep track of, that's why you have to use working memory, and that's why it's attentionally demanding and slow and effortful. Another prominent symptom in melancholic depression is anhedonia. There are different kinds of conceptions about anhedonia, and that's actually an important part of the talk, but one way of conceiving of it is a loss of interest in things that you'd normally find pleasurable. But another way of conceiving it is just, it's not the loss of interest, but the loss of the ability to feel pleasure in things that you normally find pleasurable. We have argued in our theoretical work that anhedonia allows rumination to proceed with minimal interruptions. And the reason for this is that if you're thinking about the problems that triggered your depression, your failing romantic relationship, your miserable financial situation, et cetera, it's hard to think those things through if you're also being distracted by humor and sex and food. Okay, so the anhedonia helps you stay focused. Another important symptom, which I'm going to put up here today, but I won't be able to talk too much about today because we haven't studied it yet, is that the hypothalamic pituitary adrenal axis is chronically activated. This helps mobilize energy in the periphery. It also promotes insulin resistance, and the net effect of this energy mobilization is to essentially direct it up to the brain to help support all this intense thinking that one is doing. Okay, so basically we have proposed a particular hypothesis for melancholic or ruminative depression, that it evolved to promote avoidance of some harmful outcome that cannot be avoided without the use of type 2 thinking. I should have mentioned when I talked about type 2 thinking that type 1 thinking is the quick, fast, heuristic, spur-of-the-moment kind of thinking. And so obviously there are many situations in life where quick thinking, quick action is needed, but there are others where slow, careful, methodical, analytical thinking is required. We're suggesting that melancholic depression is a response to situations that require that slow, careful, analytical thinking. And I give you two examples here. A depressive episode that is triggered by a mistake or a failure whose cause is not immediately apparent. And the reason why I say that is because if we're thinking about things in this avoidance learning framework, the whole goal is to avoid some harm that could happen in the future. And if you've just been exposed to, if you've had made a serious mistake or experienced a failure, usually you don't anticipate those, otherwise you would have tried to prevent the experience from happening. But if you want to avoid something similar in the future, you need to understand why it happened first. Okay? So if that causal question about why this mistake or failure happened is complicated, this is a kind of situation where type 2 analytical thinking could be useful. Another kind of example is where you are facing a decision where there are multiple options, and none of them immediately stand out as being the best. Okay? They may all be bad, and you have to make the best out of a bad set of options. Or they may have pros and cons to them, and you have to carefully weigh the pros and cons of each of them in order to achieve a good outcome. But that's another thing where you're going to have to do that slow, careful, analytical type thinking. Okay. And again, we just proposed that the symptoms of this melancholic or ruminative depression motivate and promote uninterrupted analysis of the triggering situation. So we call this the analytical rumination hypothesis, or the ARH. Now, I've talked about trying to understand the cause, and I wanted, as a kind of situation for which type 2 thinking might be useful. And I thought I'd give you a little bit more information about this. So in this particular figure here, I've got this woman who's thinking about some problem in her romantic relationship. And you know, I've just got an example of what I might call a root cause analysis here. Why is my partner trying to break up with me? Does my partner think I've cheated on him? Or is it because my financial future is horrible? Did I say or do something insensitive? Is there something I can do to keep my partner? What can I do to prevent this from happening again? This is a natural kind of progression of thoughts that you could see yourself going through. I certainly have in my life for things like this. And they have a particular order to them. There is first an attempt to reconstruct the causal chain of events that led to the problem. Okay? Secondly, in this attempt to reconstruct the causal chain of events, there is usually a focus on self-blaming causes. Why self-blaming causes? Why not just blame it all on your stupid partner, right? Well, the thing is, if it's an aversive event and you're wanting to prevent some harmful outcome, that's on you to prevent. Only you have control over your own actions, and if you're trying to prevent your partner from leaving or find a way to encourage the partner to stay, you're going to have to figure out something to do, so you might as well search for self-blaming causes. Make sense? Okay. In this context, so self-blaming causes, it helps promote this avoidance learning function. And it has a motivational function in that context. We also argue that the low self-esteem, which we have talked about as a characteristic feature of rumination along with self-blame, also has a motivational function. If you believe that yes, my partner wants to leave, and yes, I'm to blame, but no, I don't have any self-esteem issues over this, it kind of indicates that probably you don't care too much about whether your partner is leaving. And I've seen in plenty other examples that the low self-esteem actually just says, I am not as great as I thought I was. I need to improve myself. And low self-esteem actually has this motivational function in many contexts for improvement. And that's not my research, that's research in social psychology which has shown that. Pessimism is also an important feature here too, because if you think the future is going to be rosy, there's no point in doing any avoidance learning, right? Okay. So the final symptom I want to talk about here that occurs in a root cause analysis and in rumination is the fact that rumination is perseverative. You keep repeating things over and over again in your head. Now, one of the things that, again, cognitive psychology has shown us is that repetitive recall is actually one of the best ways to solidify information in your long-term memory. And this is what happens in depressive rumination is that this isn't something that you do by choice as you would in studying for an exam or a test in your classes, although it's really useful in that context too. This is something that your nervous system imposes on you. You don't have any control over it, okay? What it does, however, do is it does solidify information in your long-term memory. So if you're trying to go through a long chain of events in that causal reconstruction, that perseveration will help solidify, consolidate all those complex set of facts in your long-term memory, and it can help you identify those places in there where you might consider, oh, I could have done something different along this chain of events. And if I had done something different, then I wouldn't be in the mess or the pickle that I'm in now. Okay, so that is a reflection of the self-blaming causes, what I could have done, but it's also a consideration of what we call counterfactual thinking. The goal of this is to, in a root cause analysis, useful for avoidance learning, is to figure out those things that you could have done in this causal chain of events that could have prevented the mistake or the failure. And they're called counterfactual thoughts because you didn't actually do them and the bad thing did happen. Okay, so you're imagining an alternative future that could have happened. That's why it's counterfactual. And they're called upward because if you had done them, you would be in a better situation than you are now. Okay, so this is actually an important part of the talk because we're actually saying that if we can develop a paradigm for triggering and studying depression in the laboratory, we have predictions about the precise kinds of thoughts that ought to be triggered by it. Okay? So this is a former student of mine. Some of you may remember her, Stephanie Northover. She was here as a master's student in 2013 to 15, I think. And she went on to do a PhD in the States. So she's now Dr. Stephanie Northover. But she was probably one of the smartest experimental designers that I've come across. And she came up with the very clever experimental paradigm that I'm going to lead you through. Okay, now, in this particular paradigm, it requires running 3 or 4 participants at a time, 4 really, but one of them secretly a Confederate. Okay, but we'll just talk about 4 participants at a time. In this procedure, we would put them in separate rooms at first, where they would go through informed consent, provide some background information, and we'd get some baseline characteristics. The informed consent is deceptive in this case. We have told the participants that they're going to be essentially engaging in a bunch of cooperative tasks. Then what we do is we put them together now in the group room, which I've highlighted here, and they go through a guided conversation where they have to answer progressively more personal questions to each other. The experimenter is not in the room, the Confederate is, but the whole point is, the ostensible purpose of this conversation is to have people reveal some disclosing information for the ostensible purpose of promoting cooperation and trust. But Stephanie cleverly used this as a vehicle for promoting rumination, which I will explain in a bit. But think about this. There's 29 questions that they have to answer. That's important. Okay, then after that, they're put in a separate room, and they have to rank. So there's 3 there. If you consider you're one of the participants, there's 3 other participants. You're supposed to rank 2 of the others as your top choices for engaging in a partner choice task down the road. In fact, we don't use that task, but this is what's part of the narrative that the participants are receiving. And at this point, so again, they're put in separate rooms, and after this ranking, they're in front of a computer as well, and they engage in a virtual ball tossing game that's called Cyberball here. And this is what it would look like if you were one of the participants. The other 3 participants that you had met would be featured as cartoon figures with their names over them. So you wouldn't see their actual faces, you'd see their cartoon figures. And they start throwing a ball to each other. They throw it to you. You have to make a decision about who you're going to throw it to, and it goes back and forth like this. However, this is where we have randomization that occurs. And in the control condition of Cyberball, they continue to throw the ball to you at a roughly equal time as they throw it to everybody else. Okay? However, in the exclusion condition of Cyberball, they stop throwing the ball to you, and you receive a significantly less number of ball tosses. Okay. Now, the function of this is, so Cyberball by itself is commonly used to induce negative mood, but when it's paired with this guided conversation, the whole gambit that Stephanie had realized is this should potentially give people a reason to ruminate. They'd think, what did I say in that conversation? What personal piece of information did I disclose that turned people off to me and made them want to not play this ball tossing game with me? Stephanie was also a very smart, statistically minded kind of person, and she said, Paul, we need to design a paradigm that that actually creates a large effect size. We shouldn't be focusing on p-values, we should focus on effect sizes. So she decided that one exclusion event wasn't enough. We needed to put these poor participants through a second exclusion event. Okay, what is that like? So, remember I told you one of the participants was a Confederate. Okay, so in both cases here, let's just imagine you're in the control condition. We'd say to you that, oh, one of the participants had to leave early. They didn't realize that it was a 2-hour experiment, and so they have to leave after an hour. And so we can't do that partner choice task anymore, so everybody's going to do some other tasks instead. Okay, that's the control condition. But if you were in the exclusion condition of Cyberball, you'd get essentially the same story, except that we'd tell you that not everybody can do the partner choice task. And remember, there were only rankings of the top 2, and say, nobody chose you. Okay? Yeah. All right, we did get this through ethics, okay? I know, and I know you all have questions about that, okay? But hold them off. So, but remember what Stephanie, I'm trying to blame Stephanie for this. No, she was brilliant. Anyway, so we then tell you that you will do this a series of other tasks. So that's what I've got here at the bottom here, other tasks. And then finally, after these other tasks, there's a debriefing. I should mention this other task here, the one that I'm going to talk about here is something that we use in a lot of our work, and it's called expressive writing. And here at this, so people who've gone through both the control and the exclusion conditions will be given an opportunity to write their strongest thoughts and feelings about the ball tossing game. Okay, so everybody understand the design so far? Okay. Now, I'm just going to make a brief digression. We're going to do a lot of significance testing in here. And I am not the kind of person who likes, as a conceptual thing, doing Bonferroni corrections when one is engaging in multiple comparisons. Why? Well, by increasing the threshold for significance, you actually are more likely to get false negatives, right? So you solve a false positive problem, but it comes at the cost of false negatives. So I prefer just the philosophical thing of replication, replication, replication. I'm going to say my colleague Reuven Dukas first pointed this out to me years ago, and it always stuck with me at the time that the replication crisis was going on. So keep that in mind. lots of testing going on here, but what I'm really banking on is trying to convince you that this is a good set of results by virtue of replication. So we have conducted 4 experiments using this paradigm. Stephanie and a thesis student conducted a pilot back in 2014, 2015. I'm not going to provide those results here because they're much more impoverished, but essentially the same, in relevant part, the same results as the next 3, which we conducted once before COVID, and COVID interrupted us for 2 years, and then we've done 22, 23, 23, 24. The pre-COVID one has been published this year. Max Altman is, where is Max? There he is. He's the first author on that one. He's taken the lead on a lot of this work. Okay, so, and that was published in Emotion. We're very proud of that. Okay, I should also say that I haven't been smart enough to pre-register all of these, but I will say this, and Max knows this is true. We have not done any studies that we haven't also, either tried to publish or have published or intend to publish. All of the studies, that's it. Okay. The 3 studies have increasing sample sizes. The first study, 134, second, 155, third one this year, 245. My lab has gotten really good at running this. And this is a time-intensive experiment because it's like 2 hours, right? Okay, so getting 245 people over the course of a year is a quite impressive feat, and I'm very proud of them. You can see that the age is about the same across the 3 samples. It's obviously a female-biased sample. That's an important one. And I've just put the top 4 different ethnic groups in here. Obviously, there are other ethnic groups, but I just wanted to give you a smattering of the kind of ethnic diversity that we have in the samples. If you pool all the samples together, we have about 524 participants altogether. 411 are female, 113 are male. I will say that we asked both sex and gender. There were few people who identified as non-binary, but there were just too few to analyze for that, so we just went with the sex variable, okay? Okay, now one of the first questions I want to ask is, how did this paradigm affect mood? We measured mood with something called the valence arousal mood profile that measures sadness, happiness, anxiety, and calmness. There are 3 time measures that I've got up here. One is around the baseline. 2 is right after the second exclusion event. And the third one is right in the middle of the expressive writing. From the first study, we see, here's the sadness results. So time 1 is baseline, and time 2 is our most important theoretical one because that's right after the exclusion event. And what you see here is a significant difference between the inclusion and exclusion conditions in sadness at time 2, with an increase for the exclusion. There's a significant decrease in happiness at time 2, and anxiety has no significant effect. And there is a transient effect of calmness at time 2 that does not persist to time 3. Based on this, we started wondering, okay, sadness is one of our symptoms of depression. That loss of happiness can be construed as a measure of anhedonia, right? So we're seeing some effects that are suggesting we are producing some kind of depressive phenotype. But we saw that the effects for those 2 variables seem to persist into time 3, and we were like, okay, we really should be checking how well our debriefing is doing, right? Okay, so we reapplied to McMaster's Research Ethics Board to gain approval for including a 4th measure after the debriefing. So we include it there. We included this in studies 2 and 3. What do those results show? Okay, now I wish my thing would work. There it is. Okay. So what you see here is that the exclusion condition starts off at time 1 a little bit differently than the inclusion condition. So if you sort of imagine in your mind controlling for that higher starting point, the time 2 discrepancy is actually fairly significant for sadness, and we replicate both at time 2 and time 3 the same results that we had from the first study. But by the time we get to the debriefing, they're no longer significantly different from each other. And notice also that by the time of the debriefing, the participants are less sad than they were when they started off before the manipulation. And they're actually happier than they were when they started. This is telling us our debriefing is working. Okay? All right. We also saw some effects on anxiety that did not show up in the first study, and we replicated that lower calmness thing at time 2 there. And what we see now is in the third study essentially a replication of what we just showed you there. We replicated the time 2 and time 3 differences in sadness and in happiness. There's that transient difference in calmness again. Yes, people are less sad and more happy than they were before the manipulation. And actually in this study, there was a significant improvement in anxiety for those who went in the exclusion condition. Obviously, it's not replicable, but and so you got that. Altogether, I say we got evidence of 1, replicating our mood effects across studies, and 2, our debriefing is working. Okay, I told you that during, here we go. After the exclusion conditions, we gave them a chance to write. And basically, I told you it was their strongest thoughts and feelings about the ball tossing game. Participants wrote for a total of 25 minutes. There was 15 minutes of initial writing, short break to fill out time 3 mood measures, which is where you saw the time 3, and then another 10 minutes of writings. And then we had all this rich information in the writings, okay? And what did we use it for? Well, we wanted to try and get at some evidence that our manipulation was triggering some of the other symptoms that we were interested in. Self-blame, or guilt, if you will, or low self-esteem, worthlessness, right? Those symptoms. We were also interested in some of these variables related to root cause analysis, like causal reconstruction and counterfactual thoughts. We also ended up developing a guide for trying to rate anhedonia from the writings as well. I think I'm going to skip the examples of stuff from the examples what the writings would look like in the spirit of time. And just point out that in the study 1, the exclusion condition produced significantly different effects than the control condition on whether or not there was a problem, the causal reconstruction, self-blame, self-esteem, and the counterfactual thoughts were not significantly different. Okay. In running the studies again, we see that essentially all of the effects are replicated, except now the counterfactual thoughts are significant, and the counterfactual thoughts were significant in the third study as well. Okay, so what we're getting is not just sadness and self-blame and low self-esteem. We're getting happiness, sadness, self-blame, low self-esteem as variables that are conceptually important for producing a depressive phenotype. I also wanted to say, remember I said there was an order effect that we were predicting? So we basically proposed in our theoretical research that root cause analysis would be essentially a latent variable that is composed of or drives a causal reconstruction with a self-blame, a focus on self-blaming causes, and is motivated by low self-esteem. We had this idea that sadness would promote that, and that the output of a root cause analysis are these upward counterfactual thoughts. And we applied this to the model. In order to do this, we had to, because this involves structural equation modeling, you need large sample sizes to do this. So we did some exploration. Did our samples, our study, or data sets differ from each other? Not really in any fundamental way. So we just lumped them all together. And so this is the result of the structural equation model with all of the 500 people in it. And you see that this works quite well. Sadness predicts the root cause analysis, which predicts counterfactual thoughts. And this pathway here, which we did not predict to be important, was not significant. Okay. Can we do a better job of assessing anhedonia? Because I told you that the loss of positive affect, the loss of happiness, is one kind of possible way of conceptualizing it, but we wanted to do a better job. So it's this year that we started trying to do that. We created new criteria for rating anhedonia from the writings, where a higher score was more anhedonic. And in that result, our condition, our experimental condition, produced a positive estimate, which was significant, which means yes. According to the writings, people who went through the exclusion condition were more anhedonic. And similar thing here, we developed a self-report scale that was assessed at time 2, if you remember where that was, in which case, where a lower score is more anhedonic. So this is a latent anhedonia questionnaire, and condition has a negative effect on it, which is consistent with the idea that the negative one is more anhedonic, and again, it's significant. So we've got 3 different ways of assessing anhedonia, which is conceptually one of the most important symptoms of depression. I want to just quickly go and say we had participants who had reported to us whether or not they had a psychiatric diagnosis at any point in their life. We reasoned that those would be really important if we're trying to test this diathesis hypothesis, right? Because if some people are vulnerable to becoming depressed, they should be more likely to have psychiatric diagnoses. So we basically tested this, whether or not there were significant differences in the responses to this paradigm between those who lacked a previous history of a diagnosis and those who had a previous diagnosis. And the quick answer there is that no, we didn't find any evidence of that in responses to sadness, happiness, self-blame, or self-esteem are 4 big ones that we're interested in. We also wanted to see if there was a sex difference in response to the paradigm. And here we're looking for an interaction between sex and condition in this response. We found no evidence of that for happiness or sadness at time 2, once you control for their time 1 levels, their baseline levels. They did come into the lab with different levels of baseline sadness and happiness. Okay. We did find fairly consistent evidence of a sex difference in the rated variables in the writings. But it's important to realize we don't have before and after measurements of those. It's hard to know what we would theoretically imagine them coming into the lab with there. But nevertheless, want to point that out. Okay, I've gone for the 50 minutes. I'm going to take some, I do get a few extra minutes because of the intro, right? Okay, and why don't I just stop and just, I mean, you guys basically see the story. We can produce a depressive syndrome. It seems to be replicable. If the syndrome is characterized by sadness, anhedonia, measured in various ways, self-blame, and low self-esteem. Okay? We can also predict to some degree what the content of their thoughts are, which I think is kind of an impressive thing. And we have some mixed evidence. We see psychiatric diagnosis doesn't seem to make a difference, and we see maybe sex does, but it's not really clear. That's my pause, and let's just call that. Thank you. I saw Joe, Pat, and Sigal, and then yeah, Daphne.
It's a really interesting paradigm to use feelings. Do you think if the group was large, so you had there were 4 people told for the Confederate, like what if there were 10 that no one picked you? Would you be even more sad? And if you did do a debrief, how long lasting do you think the sad state would be?
If we, yeah, okay. Don't know about how long the debrief, how long people would be, sad or whatever after if we didn't do the debrief. Obviously, we are trying to make sure that people get out of that state in 2 hours, and there's a whole other ethical set of questions to assess how long this might last. Yeah, I hadn't really thought about the number of participants. I thought more about the number of questions. Like, for instance, I told you 29 was actually an interesting point, because what happens if, I mean, the whole idea of using working memories, if you're going to have to, like for instance, which of those 29 was actually an interesting point, because what happens if, I mean, the whole idea of using working memories, if you're going to have to, like, which of those 29 questions was the one, my answer to which caused everybody to dislike me? Right? Whereas if it was only one question, you wouldn't have to do that kind of calculation. And I'm looking at Bruce here in particular just because it's like I'm imagining a cognitive psychologist like yourself who studies memory and working memory might very well think, yeah, that's an interesting experiment. We ought to do that. Yeah, okay, Pat.
I actually have 2 questions. One is just when you describe your paradigm, and you said people have 25 minutes to write, I just went, my thinking was, people would have something to say for 25 minutes. Like, my own sense, like, if I was in this thing, I'd be like, I guess at this moment, who cares? Because these are strangers, yeah? They don't know these people, at least we think. And there's nothing other than the ball busting. It's not like they're interviewing for a job or something. So my one question I have is, the context in which these interactions occur presumably matter a lot and they differ across people. So are there some people in your study just like, I don't care, I guess it's their problem that they lit up or something. But the other thing is, I mean, depression presumably is related to the intensity and the duration of these moods, right, of these effects. And I guess I'd like to know, like, how transient were these things? I know you have it debriefed. If they are really transient, to what extent do they would be like depression? Or is it just like very mild depression? Is persistence necessary for something called a depressive episode?
Yeah, they're kind of related in some ways because sure, there are some people who don't write much, but there's a lot of people who spill their guts out to us. In fact, I carefully choose the people who I have work on these studies because there's a lot of confidential information in the writings. And some of it can be, I'll tell you, we do check in the writings to see if there's any signs of self-harming or suicidal kind of thing. And the reason why we do that is because, yes, some people talk about, oh, this reminded me of some event in my past where I was excluded, and they tear their hearts out over that. Or, I'm going through an exclusion event in the residence halls right now that this is reminding me of. And so I think the students who work on this know that there are a lot of people who are affected by this. Okay. The second thing, that would be related to the question of how long it might persist in an indirect way. But I would say this, that a clinician would say, yes, it does matter that it's, must meet the 2-week definition. Well, that is true. That's what the DSM says. It has to persist for 2 weeks. On the other hand, everybody who's thought carefully about that issue says, yeah, that's a completely arbitrary line. And I think, what we don't know is how long this would last without our debrief. It might last for some people days. Maybe for some people it could go in 2 weeks. I don't know. But I think the more important thing is the duration is, everybody agrees that's arbitrary. Nobody has been able to produce a coordinated set of symptoms like this before. And that allows us to get at questions of etiology that have not been available in the past. Sigal.
So I have a comment and then like 2 questions. One, the comment is that in the last couple of days I've seen a lot of news about Instagram or Snapchat because they've taken their program or whatever they do, the app, and they rank your best friends, your 10 best friends. And parents and teachers are very upset about this because people are feeling excluded and depressed, and I think you should study this and get lots of money. That's my comment.
You are the research chair of our department. Yes. Thank you.
Go get some money. The second thing I wanted to say, it is a question. Like, if I was given a survey about mood in the middle of this, I would say, these researchers aren't really studying cooperative behavior. They're studying my mood. And I would see through that. And I wonder, like, do people see through this? Does that matter? Like, maybe they want to tell you what you think you want. They think you want to hear, but they know it's about mood. How do you know they don't know it's about mood?
Yeah, that's a great question. I can tell you that we do keep track of information about suspicion. But I'm going to let Max answer this in greater detail.
Yeah, so during the debriefing process, the first thing we do before we debrief is we probe for suspicion. And also, if people guess like what the paradigm is trying to do, and we ended up excluding their data from the analyses. But sometimes people just naturally, very common thing people would say is, I think this could be fake, but I don't know, and then they go into all of these ideas. So we have to use some discretion of how much suspicion is too much, but we did always look for engagement.
Okay. My second question has to do with culture. Things have happened that are very extreme in the last few years. We had the pandemic, all kinds of, the world is changing. And I wonder about your repeated results, which are brilliant. Do you notice cultural shifts in your data? Do you get the same kind of effects throughout all the repeated times you've done this?
So far. But you know what? That's another really great question because having known about other kinds of work on depression, like if you want to test cognitive behavioral therapy and whether that works, what you see over time is that the effect size of CBT has diminished over time. I actually have been somewhat worried about just getting publicity for this research. They're like, what's Dr. Andrews doing, But the other thing is, if so many people become aware of this research, the ability to actually produce an effect might very well be diminished. So far, we've kept this pretty much under wraps. So,
We should all keep it under wraps.
yeah, be quiet. Shh. Okay, I think, sorry. Yeah. Oh, it was Daphne. Okay, yeah. And I think I need to get some students in here too.
Thank you, Paul. Really interesting development of a paradigm. So let's suppose it's well established, it's published, you've done that. Now, how are you going to use it to study depression?
Well, in some sense, I've tried to give you a hint about that already, because we didn't find that psychiatric diagnosis actually made any difference.
But you didn't have a big N.
500 people.
No, it's like, you didn't have
Oh, yeah.
more people with psychiatric.
Yeah. No, that's true. Yeah.
Okay, suppose it goes
But-
up.
but- but yeah,
Tell me
but-
what that would tell us about.
What I care about that is, okay, I actually think a good alternative hypothesis to the stress diathesis hypothesis is that we all have an adaptation in our brain for producing ruminative depression under certain evolutionarily relevant conditions. Social exclusion is certainly one of those. I am interested in testing whether or not, having a psychiatric diagnosis really is an index of response. If it were, it would help build the case that maybe there is something going wrong in the brain and that our diagnostic system actually may not be perfect, but at least is doing some kind of decent job. On the other hand, if we end up, the results hold up, that there are no significant differences amongst people with and without psychiatric diagnoses, then I think that's going to, reinforce the case that this is a normal emotional response. I should also point out, that we are using this in, young adults, reproductively aged. These are, that's the time in life when selection against dysfunction should be at its greatest. So the fact that we're triggering this in a young adult sample is, in my mind, relevant. Yes, sir.
So everything we always hear about anhedonia is about how it's like a chronic, persistent lack of pleasure derived from pleasurable ability or activities and things like that. So I'm a little stuck on the logic of tying a kind of transient, self-reported happiness that seems to undergo these shifts, these statistically significant shifts, multiple over the course of like 2 hours. And then I appreciate that you said you wanted to get a better judge on that from their writing samples. So what are they writing about, and how do you quantify the anhedonic nature of writing on those subjects?
Okay, so this was a thesis students project for this year. So Charlotte DiBiase, there you are, okay. Why don't you help explain how you conceptualized anhedonia and the two different primary measures that we use. We use the self-report questionnaire and the concept from the writings, yeah.
Yeah, so in the literature there's a bunch of different types of anhedonia, and they seem to be related to the reward system. Two major types in like major depression are consumatory and anticipatory anhedonia. So it's like a lack of ability to feel pleasure from rewarding activities and a diminished ability to feel pleasure from anticipating future rewarding activities. So there's been like a few anhedonia questionnaire measures that have been like validated and shown to be reliable in studies on major depression. So what we did was we took some questions from like these well-validated questionnaires, as well as developed some of our own that related to the current paradigm. And then participants filled this out at Mood at time 2 after the exclusion, where we saw those significant differences between groups. And then as for the rated variables, we had a rated variable to do with anhedonia, to how to identify it. And that was like rated on a level from 0 to 3, which blind raters were trained how to identify this. And we again saw significant difference between groups for this variable.
I'll just follow up. Thank you, Charlotte. I appreciate the question about isn't anhedonia a persistent thing and having trouble conceptualizing it. I'm going to go back and say that's the same. I'm going to have that same response. I mean, look, we don't know how long this anhedonia would last if we had not used our debriefing. But to me, the time frame, those kinds of things are arbitrary. I don't think we ought to be, hanging our hat on arbitrary thresholds for things. But the idea that you can produce a coordinated set of symptoms that we know from a clinical perspective hang together and are clinically meaningful, to me is the more important thing. But it's an obvious limitation, and then is it possible someday we could actually, I think it would be a risky kind of experiment to do to not give the debriefing, but if you could imagine doing that in some way that protected participants, right, then we could maybe answer some of those questions. I think we should, Pat's got his hand up, but is also, yeah, Ali.
I do want, and then we'll wrap it up. Part of the paradigm is socially excluding these folks and then letting them sort of sit alone in that room with their feelings about it, right? And trying to engage in root cause analysis. What if you prevented the need for RCA? What if you told them this person did it because of this answer, right? They don't need to engage in that activity anymore. Would it prevent these feelings?
So I think that's an excellent question, and it's sort of similar to my conception of what if we instead of 29 questions had one question, right? That solves the calculation problem. The other way of doing it is to give them the answer. Yeah, I think, first of all, I think people are still going to have some aversive feelings. They might get angry, right? Oh, that jerk. They did stop throwing the ball. They dislike me because of that, or whatever. But yeah, I do think we would have a different response in terms of emotion. Probably the sadness and, yeah. I would predict definitely there would be a difference. Yeah. Is there Paul Four, yeah.
Actually, I was going to ask a question similar to Ali's about during the rumination phase, what if you had their paired with someone who can either also had exclusion or who did not have exclusion? They'd have someone to talk to versus someone who's unpaired. That's another manipulation to see how the rumination effects persist.
Okay, that's an interesting thought. Thank you, sir.
Can you join me in thanking Paul for a fantastic
Thank you.